This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters, Television for Life.
I was fine, I thought. My husband and I were walking 6 miles a day.
A Spokane woman with a family history learns she has lung cancer.
I was scared because cancer is dominant in my family on both sides.
Her story, from a trip to urgent care to weeks of chemo, all leading up to the ultimate good news.
My doctor said, "You're cancer-free."
Health Matters looks at lung cancer.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
Good evening, and thanks for joining us. I'm Teresa Lukens. More than 1 million people are diagnosed with cancer each year, yet one type stands out, and that's lung cancer. It's America's #1 cancer killer and the topic of tonight's show. In the next hour, we'll look at the risk factors and the latest treatments, plus the strong link to smoking. And here to lead the discussion is our panel of experts. Dr. Kevin Mulvey is a medical oncologist and director of oncology services at Kootenai Health. Dr. Jiten Patel is with Providence Pulmonary and Sleep Disorder Clinic. Dr. Aaron Wagner is a radiation oncologist with Cancer Care Northwest. And Dr. Stephen Nisco is a thoracic surgeon with Northwest Heart and Lung Surgical Associates. And I want to welcome all of you, and thank you so much for being here for this important discussion. I'd also like to remind you tonight that we are streaming live on Facebook, and we do have an expert available to answer your questions there, as well as right here. We do welcome your phone calls and your emails on the topic of lung cancer. And I want to begin tonight by talking about why lung cancer is so deadly and the deadliest of the cancers. Dr. Patel, why is that?
Well, it's a very dubious presentation. It can be a patient without any symptoms to someone who presents with chronic cough, or it's an incidental finding on an image for another reason. And when it is diagnosed, it's usually diagnosed in later stages where cure may not be as an option. And so that's why it becomes such a deadly disease.
And is it because it can move throughout the body before it's detected?
Yeah, there's two major types of lung cancer. The majority of our lung cancers that we deal with are what are called non-small cell lung cancers. We hope to catch those at a curable stage where either surgery alone or surgery in combination with chemotherapy and radiation may be curative. But as Dr. Patel said, very often when people present, it may be beyond that. There's another type of lung cancer called small cell lung cancer. It's only about 15% of all lung cancers, but that one is a highly aggressive cancer, and it's rarely curable.
Dr. Wagner?
And as Dr. Mulvey was saying, they do have a high chance of spreading compared to some cancers, especially small cell lung cancers. They very much like to spread throughout the rest of the body. And as was mentioned, you know, it's a cancer that can frequently grow to and be there for some time, you know, before their symptoms actually to make it present, which is why about 3/4 of lung cancers are found in later stages or metastatic settings versus some other cancers where they're in an area where you get symptoms much sooner, and so you find them at earlier stages, and therefore they're much more curable compared to some other cancers. But
I think that's a very important point. The inside of the chest is a very big place, and we can't really get at it. You can't feel things in there, and the lungs take up a lot of that space. So without imaging that we get because someone fell and we check something, or looking at the chest with some picture, things can get quite far along. And that's a big disadvantage to the patient when we find out that they have lung cancer. It's been there for many years, it's big, and it's spread to other areas. And that's one of the reasons why the results can be disappointing at times, and why we are trying so hard to find people earlier in their process.
Why aren't we talking more about it?
I think it's related to the stigma of tobacco-related disease, and some are hidden smokers, and it's not as approached conversation. there is an element of not knowing, and I think the key is to ask your GP if they do have symptoms that are persistent. A lot of these cancer patients present with incidental findings of a cough that persists for weeks after a flu-like symptom, maybe odd weight loss, night sweats. Sometimes they cough up blood. Other times they have no symptoms. But it's important to be engaged in their health. And if they are a smoker, which is the leading cause or risk factor for lung cancer, we should be talking about tobacco cessation.
So much of our discussion is probably going to be surrounding tobacco use. What is it about tobacco that causes lung cancer?
There's about, I think they estimate 150 chemicals in cigarette smoke that may be potentially carcinogenic. Having filtered cigarettes does not actually eliminate those carcinogens. It's honestly one of the most, tobacco smoke, one of the most deadly, poisons that we have out there.
And so if somebody is smoking now and they've been smoking for years, can they cut down on their risk of getting lung cancer, or is it
absolutely
after many years of smoking?
Yeah.
Absolutely. I think the benefits are almost immediate in what happens to their blood pressure, their risk of a coronary or heart event, a heart attack within 1 year is that of a non-smoker. Within 10 years of not smoking or cessation, you're almost that of a non-smoker risk of having lung cancer as well.
Many people know that smoking isn't good for them. We've educated our population, but it's very addictive, very addicting. And a lot of people who are smoking aren't wanting to know. And they want to take, they're afraid of a picture, they're afraid that they can't quit. Getting people engaged in trying in a healthy living and understanding that there are tools to help you quit smoking, and if you do, you dramatically decrease your risk of dying from not only cancer of the lung, but other cancers, and of coronary artery disease, which is our leading killer in the country. So our leading cancer killer and our leading overall killer are both directly tied to cigarette use. So that's something that we've made a lot of progress on, but there's a lot more work to do.
Mm-hmm. It isn't the only risk factor, though. It is the biggest one, but there are others.
There are. So cigarette smoking is probably responsible for about 85 to 90% of lung cancers on average. But there are others in there. That includes, environmental or occupational exposures, basically things that are irritating to the lung. So that chronic irritation to a very sensitive tissue is kind of what predisposes you to cancers. And then there's others as well, includes radiation, radon exposures, things like that. So there are, but there's just a much smaller percentage. And as I mentioned, we have actually made a lot of progress in terms of smoking cessation. And it's interesting, even though lung cancer is still our leading cause of death in the country, the incidences of lung cancer are finally decreasing. It's finally catching up to in terms of the kind of the education we've done. And so it is progress, but it's just a slow time coming. So.
Mm-hmm. What about secondhand smoke? We're even now hearing about third-hand smoke, which is the residuals from even being in a room where someone has smoked. What are the risks involved with secondhand or third-hand smoking?
It really depends on how much. Okay, so it really correlates to, how much you've been around that and for how long. It's really all a dose-related problem.
Mm-hmm. What about children of smokers?
Again, certainly there's two problems there. You're exposing your children to secondhand smoke, but you're also exposing them to them thinking that smoking is okay. And so it's a double whammy there.
Mm-hmm.
To lead to that, as tertiary or third-hand smoke through clothing, particulate matter does lead to inhalation airway disease and causes coughing and wheezing. Secondhand smoke as well. Growing up, we grew up in a generation where you went to a restaurant smoking or non-smoking. You go to the lavatory on an airplane, you go through a plume of tobacco. And so it leads to, over time, number of years that patients smoke or had smoked, the number of cigarettes per day equals a risk factor of so many packs per year. And it leads to this slow degeneration of DNA and leads to tissue injury at a tissue level, a small cellular level. But it has an enormous impact on your children, your community, and the patient as a whole.
What about family history? How does that play in?
It's not as compelling a risk as it is for other diseases, for instance, breast cancer and ovarian cancer and prostate cancer. There are some rare types of lung cancer that may be related to inherited predisposition, but for the most part, it's more environmental.
Okay. Let's talk about the symptoms then. Dr. Patel, you mentioned a few of those things off the top of the show, but what are some of the things? I might have a persistent cough, but that might not alarm me immediately. And again, because it is so difficult to know, what are some of the other things you need to really be aware of if you also have that cough and other symptoms? What are some of those symptoms, Dr. Wagner?
So cough is a big one. You know, chest pain, if you have tumors that had to be, you know, fairly close to the chest wall, you can start to develop pain from that. Sometimes hemoptysis, basically meaning that you're coughing up some blood, and a lot of times that's small amounts. It's you're coughing up sputum and you end up getting some blood tinges to that. That could be another common one. And even some very generic symptoms. So, you know, getting much more fatigue, getting a lot of weight loss, things like that that are just unexplained, that weren't intentional, kind of at the same time as you're having a cough can certainly contribute as well. Shortness of breath is another common one. And some of these are hard because they blend very well into other conditions that people have for lots of reasons. You know, a lot of times, you know, especially going back to smoking, if you're a smoker, then if you have under lung conditions such as COPD, you're always short of breath a little bit. And so so it can be hard to separate them out, but those tend to be the most common. So,
anyone else?
Unexplained weight loss is often one we find, and that's a generic sign of malignancy. But if we can't find something, again, lurking in the chest can be a lung cancer and presenting with weight loss. Maybe there's a cough and a smoking history, so it prompts imaging. Hoarseness, we see that for the vocal cord nerves traverse through the chest, the left side on the right, left side a little deeper, and if there's tumor starts to involve one of those nerves near the bronchus and near the pulmonary artery, people can get hoarse. And they wonder what that's about. And I think they're talking too much, or just it's the smoke itself. It can be malignancy in the chest.
So when red flags, I guess, and because people tend to be diagnosed a little bit later in the process because they're not recognizing those symptoms or not putting them together. Or I guess how do we tell people to be sure to watch for those, and at what point do they see the doctor?
Well, and that's part of the challenge is there's not always an easy answer to that, which is why we kind of have a pause there because, you know, and a lot of times it's things that are, you know, changes that just don't go away, you know, so, you know.
For how long?
For months a lot of times. I mean, it's one of those things you hope to catch it quicker than that, but frequently that's kind of the time frame before people tend to get worried about it. And to some degree, that's the time frame it takes to rule out other causes for some of those things as well. So, you know, it's one of the reasons that I think these days, you know, on a slightly different topic, we're starting to push a lot more towards screening, you know, because these symptoms are not perfect, because of the fact that there's not a perfect constellation of if you've got this, this, and this, there's a 90% chance of lung cancer, that's when you go in. Because of that, we're starting to say, well, if you have the risk factors, if you meet those, then we're trying to push more for lung cancer screening to basically find it before the symptoms are what drives us to find it. So
yeah, let's talk more about the screening process and who should be screened and what's involved with that.
Well, if you're going to screen people, they need to be someone who will benefit from an intervention and who's likely to have cancer. So you don't need or want to screen.
You have to get them there for the screening.
Yes, but they also need to have some risk. So you don't want to screen everybody. First of all, some people may be at very high risk for lung cancer, but they're not going to tolerate an operation or chemotherapy, and it's not appropriate. So if your grandmother's 88 years old and she's made it smoking her whole life, starting to screen her for lung cancer might not make sense. And also, if your teenager at age 25 is smoking, he's damaging his lungs. He's creating precursors of the damage, but he's not going to get lung cancer at that time. So there are guidelines about this, and in general, we're looking to people who have accumulated enough damage over time, so they're likely to be at increased risk, but could tolerate interventions and biopsies and potentially treatment. So 55 to about 80 years old are the general age where we should be actively encouraging our people with a heavy smoking history, not everyone, but who's had at least 30 years of smoking and recent smoking, to consider imaging. And that will make a tremendous change. Compared to all the other screening tests, we pick up many more lung cancers with lung cancer screening than we do with breast or colon. We have to go through many more tests. There are some caveats. There are a number of things that can present in the lung, and sometimes we find something and we say, you know what, that could be anything. It could have been there for a long time. We're going to relook at that. And it creates anxiety. People are like, I've got So screening needs to be accompanied by some counseling, because there's going to be tremendous anxiety in our smokers about, I'm going to go in and they're going to find it, and they're nervous, and I'm just going to stay home. And so we have to combine the screening with counseling and care so that we don't have so much anxiety and that we don't over-test every spot and dot. Because some of them are just benign little old infections and aren't going anywhere.
Okay.
It's one of the downsides, unfortunately, to screening is that we want to make sure that there's an impact on health. And lung cancer screening has been shown to reduce cancer-related mortality by 20%. It is a significant impact. One of the other side benefits of it is that we can then hopefully intervene in terms of initiating smoking cessation to those folks. Those folks who are willing to get screened are more willing to stop. So it's kind of got a double benefit.
Okay,
Yes.
we're starting to get some phone calls this evening. We have a question from Joan here in Spokane. Joan, thank you for waiting.
You're welcome. I'm calling about screening for lung cancer. I was a smoker from the... Hello?
You're still there, Joan.
Okay. I was a smoker from the early 60s and quit in 1985. I'm 75 now. My question is, if I wanted to get screened, my lungs checked out to make sure that they're right, can I do that on a regular basis with a physician? Or because it's been so long, am I eliminated from being a candidate for lung cancer?
That's a very good question. Thank you, Joan.
So the United States Preventive Task Force recommends lung cancer screening, like Dr. Nisco mentioned, from 55 to 80 years of age, who have smoked for a minimum of 30 pack years, who have continued to smoke, or within 15 years of abstinence. So she smoked since 1960 to 1985. So she may be outside the recommendations by the U.S. Preventive Task Force. Having said that, if there are symptoms of persistent cough or she's concerned, there's no reason why she shouldn't engage her primary doctor to address just surveillance and talking to him and having a listen.
So the screening is really focused on people who have no symptoms. Okay, so if you've got symptoms, that's a different, that's not screening anymore. Okay, that needs to be evaluated.
Okay.
But I would encourage her to seek out a physician. She may be due for a chest x-ray. When we talk about screening, we're talking about a specific test. And this is a low dose CT scan, which gives very high definition. It's a pretty substantial test. And so it's meaningful. We're not just going to do it on anybody, but someone who's had a long smoking history and is worried should discuss with their physician what are the risks that they may have accrued. I congratulate you for having quit smoking so long ago, and you've radically reduced your chances of dying of cancer. I think that's fantastic, but they're not to zero, and many non-smokers also get cancer. So so there's a reason to see your doctor and have a talk about what should be done, if anything, to assuage your concerns.
Yeah, it's nice that she's very aware of that too. Well, coughing and trouble breathing and chest pains are some of the signs of lung cancer, but how do you really know? In the case of a Spokane woman, it was a trip to urgent care for pneumonia that led doctors to the diagnosis and treatment that saved her life.
In the weeks leading up to her diagnosis for lung cancer, Michelle Williams says she felt great.
I was fine, I thought. My husband and I were walking 6 miles a day.
Then one day in August, out of the blue,
Real bad chest pain. The breathing really hurt to where I actually fell on my knees. It was that painful.
the pain went away that night. Michelle figured it was a pulled muscle at first.
And then it happened again the next day.
When the pain came back a third time, Michelle went to urgent care.
They took a chest x-ray and they said they noticed something, but they weren't sure. They wanted a second opinion.
She was moved to Sacred Heart's ER for more tests and eventually a dual diagnosis.
At 10:30 that night, they told me I had pneumonia and I had lung cancer.
Even with her family history, it was a lot to take in.
I was scared to find out anything because cancer is dominant in my family on both sides.
After consulting with several doctors, Michelle decided radiation and chemo were her best options.
I really didn't want surgery. So that's what my husband and I talked about, and that's what I did. I had no choice, so you do what you have to do.
About 2 months after that visit to urgent care, Michelle was in treatment 5 days a week at Cancer Care Northwest.
I didn't get nauseous, I didn't get sick from the chemo or anything like that. I always had like maybe an upset stomach, so my main go-to was Lay's potato chips, and that kind of settled me down.
She did lose her hair.
I was just hoping if it came out, it would come back in purple or blonde, and it didn't.
By her side, 24/7 was Michelle's husband.
He did everything. Without him, I know I couldn't have gotten through it.
And her chemo buddy, a stuffed rabbit.
His name is H2, Hoppy 2.
Michelle, a lifelong smoker, quit and promised to fight.
It's scary, it really is. But if you give into it, who wins? Not you.
Still weak and underweight, Michelle has finished treatments. She's back to walking with her husband, enjoying each day, especially since she got the news she was hoping for.
I was found out April 3rd. That's what my doctor said, you're cancer-free. I made him repeat it like 3 times, and then I looked at my husband and I kind of cried.
Michelle beat the odds and says she takes nothing for granted.
As my mom said, you have to keep your sense of humor. If not, you might as well pack it up.
Well, I think a couple of takeaways from that. She has an incredible attitude, for one thing. And then making that decision on her treatment, whether she was going to do chemo, radiation, or surgery. And she was actually a patient of yours, Dr. Patel.
Yeah, she's a tremendous, courageous woman. Just an amazing soul, absolute salt of the earth. But that decision-making requires a multidisciplinary approach. And I'm not without wings with assistance from a surgeon or the medical oncologist and radiation oncologist who helped her figure out her therapeutic pathway. It's not the same for every lung cancer patient. And once they go through the diagnosis, the next complicated portion is staging. And there's additional testing. And then once we decide through a multidisciplinary approach what is her best options, she has to weigh in the risks and benefits.
Talk more about staging. That's determining at what point the cancer has advanced to, yes?
Correct. So there's a whole series of tests that go into that staging process. And nowadays, probably the most common staging procedures are mostly imaging procedures, including a PET scan, which is a new type of scan that takes advantage of the metabolic activity of cancer. And it's potentially more sensitive than other older imaging procedures. And then often we also need to image the brain because it's one of the favorite places for lung cancer to spread. So those are and then often the other important piece of this is how good is the patient's lung function to begin with. Obviously, smokers may have underlying COPD or other problems that could limit their treatment options. And then ultimately it does come down when we get all this information together, we review the pathology with the pathologists, we review the imaging, and usually as a group, we kind of come together with a consensus recommendation for what the next steps would be.
And talk about that combination that she used, Dr. Wagner, of radiation and chemo.
So chemotherapy and radiation are generally what the approach we tend to take for slightly more advanced lung cancers. So when cancer is spread a little bit more from just being a peripheral lung nodule to getting into the lymph nodes, and in particular some of the central lymph nodes in the center part of the chest, we know that ends up being their best treatment options. And so typically what we consider stage 3 lung cancer patients as candidates for doing a combination of chemotherapy and radiation. We'll sometimes do it in other scenarios as well, but that's the most common scenario.
And she chose not to go the surgical route, which worked for her. When would you step in? When would surgery become essential?
Sure. Well, the surgeon gets involved for a couple of reasons, and of course, each patient has an individualized treatment, largely based on their stage, with the more advanced stages not being benefited much by surgery, and the early stages being highly benefited by surgery. But there are two primary focuses for the thoracic oncologist. One is to confirm the validity of the PET scan. I remember, Teresa, when I first saw a PET scan about 10 to 15 years ago, I looked at my partner, Vern Holbert, and I said, Vern, we're going to be getting this test on everybody. This is amazing. And he looked at me like, What are you talking about? And of course, it's essential. No one can come into our operating room without the test. It's a wonderful test. It's colors, the patients can understand it, but it's not perfect. It has about a 15% chance of being wrong on both positive and negative. And what I mean by that is sometimes there can be a little bit of cancer in a lymph node, but not enough to light up the PET scan. So that's a falsely negative test, and that happens 15% of the time. Other times, a lymph node is reactive, and our patients are smoking and have inflammation in their lungs, and that metabolic activity that Kevin talked about is showing up in a lymph node. We think, oh, it's spread, but it's not. So the surgeon needs to, when they see a patient, think about confirming the stage and making sure that the whole team has the right stage, and also that once we establish that stage, that the right treatment is had. So I'll often get involved when I first see a patient, in a staging study to biopsy some of the lymph nodes and make sure the imaging test hasn't misstaged the patient and the patient needs the medical and radiation therapy more than my help. And then we'll proceed, if correct, the test, which 85% says no spread, great. You're now an early stage patient, and you're most likely to benefit from an intervention surgically.
Okay. We're getting some more phone calls. Dave from Calgary, thank you for holding.
You're welcome. Thank you very much. First of all, I'd like to congratulate KSPS and your panel for this excellent program. And I have a question. Our federal government has decided that it's a good idea for our country to legalize marijuana, cannabis. And I just wonder if there's any studying being done, or if your panel would comment on the risks of smoking marijuana, cannabis, as opposed to tobacco. And what I'll do is I'll hang up and I'll listen to the answer. Thank you.
All right. Thank you, Dave.
It's a loaded question.
Well, and it's legal here in Washington, so
right.
here we are.
And so depending on where we are in state line, having said that, there's innumerable evidence on tobacco and lung cancer. There's some bench signs being done with marijuana use, but it gets a little bit more complex about the constituents of cannabinoids and becomes somewhat of a tangential issue. But as far as I know, there's no immediate risk factor with marijuana use and lung cancer.
And part of it is even people who smoke a lot of marijuana don't get anywhere near the amount of smoke that people who smoke cigarettes. So it's a dose issue, and I don't think there's really good data, unfortunately, at this point. It's certainly not good for people who have underlying lung disease. That can be problematic for them, like asthma and COPD, but I can't say that there's really good data yet about lung cancer.
Okay.
There may be a slight increased risk if they mix the cannabis with tobacco.
Okay. Sonia here in Spokane. Sonia, thank you for calling.
Hi, I just have a question. I'm 83 years old, and they say I have a spot on my lung, and I don't want to do anything about it. How long do I have before it spreads?
Well, I think the doctors might need a little more information, Sonia.
That's a common.
Is it common?
That's a common one.
Absolutely.
And first of all, Sonia, there's a lot of reasons to have a dot on your lung, and that having a dot on your lung does not mean you have lung cancer, and it doesn't even mean we need to do anything invasive at this current time. But certainly your doctor can look at it, have some idea about what we call the pre-test probability of this being cancer. We very often want to re-image it in 3 or 6 months to see if it's moving. Maybe it's been there for the last 60 years and there's nothing to do. So I would, before you get too alarmed, I'd get some counseling from your doctor, because just many spots aren't lung cancer. If you've been a heavy smoker and still are, then we get more concerned.
This is another place where that PET scan actually is very helpful if it's a suspicious lesion. If there's something about it that is concerning, the PET scan can often give us a clear idea whether this is likely to be malignant or not.
What are the spots if they're not cancerous?
So spots in general, academically speaking, are considered pulmonary nodules. Anything less than 3 centimeters is considered a nodule, which tend to be benign. Anything greater than 3 centimeters can be something that we should be looking at again in 90 days or 3 to 6 months, because you really don't know. It's just a picture.
What causes them?
Well, it depends. It could be if you're a farmer in the Midwest have these wheat allergens and spores. If you come from the Sanquinine Valley, there's certain granulomatous diseases that you inhale and your body reacts by quarantining them and calcifying these nodules or these spots. If these spots grow, they may be relevant only if they grow. And you may only gain relevance if you follow them. If they stay the same for a year or 3 months or it's unchanged, it really doesn't matter.
Our lungs are exposed to the outside world. So we think of them as being internal, and technically they are, but we're breathing in air. So there are a number of things that can end up in your lungs that are both chronic or inflammatory and not proliferative or not cancers. But I must say, when we take pictures of them, we can certainly couch the odds. To call a spot like they're all nothing, we certainly well know spots that are almost certainly benign, and there are other spots we look at and we're like, that's most likely going to be a problem. We still may choose to image it in a short interval to avoid unnecessary biopsies, but if it doesn't go away and it looks worrisome, and we're in a high-risk demographic, a smoker in the 50 to 80 year, we're going to be more than likely inclined to try to recommend either more specific imaging, a bronchoscopic biopsy, a needle, or even a surgeon going in with a telescope and taking a look. So.
And this is a common question that is very scary for a lot of patients because, I mean, it's very common that we do a CT scan for just about any reason that you do see these little tiny nodules. And one thing I think it's important always to tell people when you tell them they have a spot is the odds of it being a cancer, as you mentioned, because we have fairly stringent criteria to try to help predict the likelihood that these are worrisome. And that's based off of the size of these nodules, it's based off of how solid versus how not solid they are, whether there's spiculations. As mentioned, there's lots of different characteristics which can make them more or less concerning. And so we have fairly algorithmic approaches towards how we follow them. And really some of them are so obviously benign that we just watch them, or we don't do anything actually about them. Some of them are suspicious enough that we do CT scans in either 3 months or 6 months, and we have criteria for kind of how often we do that. And some of them are, as mentioned, so suspicious that we don't stop there. We actually end up recommending a PET scan or biopsies to help verify it. But there is very good ways to approach that so that it's not quite so scary as somebody hearing, hey, I've got a spot and don't worry, we'll just watch it. I mean, there is good ways to approach it to make sure that it's not being missed.
Their previous smoking history is a huge factor in this, and those who are non-smokers, the risk of these nodules being malignant is much, much lower.
Yep.
Okay. Edith in Calgary. Edith, thank you for calling.
Hi. My question is, I have a disease called Neurosarcoidosis. I did have thyroid cancer, and they did a dye scan on me and found all these nodules on my lungs. That's how they discovered the Neurosarcoidosis. And I was wondering, and so it's on my lungs right now. I have all these little bumps on my lungs. I've never smoked. My breathing is very good. My question is, could I get cancer on my lungs from this? The disease is, a lot of doctors don't seem to know a lot about it, and it affects your mobility. My legs are kind of numb, but anyway, and this sarcoidosis can move from my heart to my lung, or my lungs to my heart, or whatever. But I was wondering, could I get cancer from it?
It's a great question. I'm sorry you have neurosarcoid. It's the rare of rarest. It's less than 3% of all sarcoid patients can get a organ dysfunction, which is your brain. But sarcoidosis is an autoimmune disorder that can present with lymph node enlargement. It can present with scarring the lungs. It can present with nodules or spots that continue to progress or burn themselves out and go away. But there is no risk factor, immediate risk factor for nodules from sarcoid related to lung cancer. Having said that, sarcoidosis is stage 1, 2, 3, and 4 based on imaging studies. Stage 4 is where you have lung scarring, and lung scarring, and correct me if I'm wrong, may have a slight risk of developing scar carcinomas or cancers from scar.
Okay. When it comes to treatment, Dr. Wagner, I want to get back to radiation. That word often scares people. But there have been some fairly new technological advances in radiation that makes it safer.
That's correct. So radiation is, as you mentioned, something that is very scary to a lot of people just by name. It's kind of a stigma in our society in a lot of ways, but it actually is very, very beneficial in a lot of cases. I mean, a lot of my colleagues and I like to prefer it termed as healing rays because of the fact that it's very helpful. But it's changed a lot. In the last decade and 2 decades, it's a completely different world than it was in the past. And a very good example for lung cancer, for example, is the evolution of the ability to even do something called SBRT. And this is just kind of to demonstrate some of the options we have now. SBRT stands for stereotactic body radiotherapy, and what we're doing in that case is delivering these very highly precise, very accurate treatments with very, very high doses of radiation, so much so that you pretty much ablate whatever you hit when you do these treatments. And that's very different than radiation treatments that people typically hear about getting for prostate cancer, breast cancer, a lot of other cancers, because in those scenarios, we're actually purposefully trying to treat very large volumes of tissue that potentially contain just microscopic cells, and we have to go very slowly, very gently to make sure those tissues aren't hurt, whereas in SBRT, we say, you know what, we actually know exactly what we want to hit, we're going to focus on that, and we're going to ablate it. To do that in the lung is something that we didn't used to be able to very easily do safely. And one of the reasons is that, you know, lung tumors, they move a lot as you breathe. And so as everybody breathes in and out, that lung tumor moves up and down, and sometimes that can be a very large area. And so you don't really want to ablate that much normal lung tissue sometimes. And so, you know, technology is advanced enough now where we can actually do what we call 4-dimensional CT scans, where we actually time CT scans to people's breathing cycles so that we can actually monitor and actually evaluate that motion envelope, and we can account for that when we do these very ablative treatments. And even more recently now, we can say, you know, if we want to treat just during a portion of that, we can. So for example, if a tumor is moving up and down by a couple centimeters, which they occasionally do, we can say, well, we don't want to cover that whole region, we just want actually the machine to be on during a very, very, you know, small portion, like you know, just when people are maximum at exhale or maximum inhale, for example.
Wow.
And because of that, we can actually do treatments now that are treating a very small amount of tissue and very, very effectively. And it's again, something that just didn't used to exist. And so it's all due to some of the technological advances we've had. And ironically, even though that's one of the most powerful treatments we do, actually, it's one of the most effective and powerful treatments we have, it's also one of the ones that causes the fewest side effects because we're treating such a small volume of tissue. So, so it's a, you know, again, completely different than what somebody would have experienced 20 years ago.
Wow, yeah, not nearly as scary.
It's a great option for people who have early stage lung cancer but are potentially not a good candidate for surgery because of their poor lung function, because they're not going to lose a large portion of their lung. It's only going to be a very small area.
We have a Facebook question via Facebook coming in. Are there suggestions from the panel for individuals that think they may have been exposed to asbestos, such as during a house remodeling?
Asbestos exposure is a latent disease, usually 20 years. Having or work exposures, occupational exposures, having worked with it, mechanics, you know, plumbers, navymen, and it usually takes about 20 years to actually manifest as a radiographic disease or lung disease. But the immediate exposure, I don't believe so.
So if you're tearing into a house remodel and...
I think we have to be cognizant of the age of the house, and there's some other, you know, rather constructional issues, but you should use precautions if you're doing any demolition work or construction work and exposing any insulation and other aerofibers that are very small and can lead to airway inflammation, not asbestosis or asbestos. But that is a concern in some of the older homes.
Okay. Leslie in Spokane. Hi, Leslie.
Hi. I'd like to thank our hostess and all 4 of our physician panelists for being available tonight for our questions. I am someone who has not ever smoked, but grew up in a household of smokers. I'm 3 months shy of 60, and I do have COPD. I use air 24/7 up to 24/7, and I'm concerned about what is the likelihood of the COPD, and I do have both types of COPD, lung cancer.
All right. Thank you, Leslie. Were you able to understand?
I think so. She's got under. I'm going to defer to Dr. Patel since this is the kind of patient he's going to see.
It's bread and butter, pulmonary medicine, and unfortunately she's that 1 in 4 patient who was exposed to tobacco, not as a primary smoker, but I think I heard secondhand smoke. And you can develop, the acronym COPD means chronic obstructive pulmonary disease, so it's an issue with not necessarily breathing in, but breathing out. And there's probably some other additional issues that she is having to deal with being on oxygen. But when you have limitation of flow of air out, it causes shortness of breath and coughing. Now, lung cancer itself, majority of patients are smokers, as we said, upwards of 80%, and they will have some element of obstruction or obstructive limitation or shortness of breath related to inability to breathe out. It's not necessarily a primary risk factor, it's a comorbidity with lung cancer, right? But it needs to be addressed through need for oxygen. There's certain inhalers that are available that are fantastic, that can improve the dynamics of the airway and reduce that limitation of that breathlessness or that burden of or hunger for air that she's suffering from.
Okay. Bonita here in Cheney. Hi, Bonita.
Hi.
You have a question?
I do. I was diagnosed when I was 32 with sarcoidosis, and I've noticed more in my 40s that I've kind of had a chronic cough where it comes and it goes, and I didn't know if that's something related or if that's something that I should really, really talk to my doctors about. I did go see my doctor a couple weeks ago, and she told me to try a few other things and then call back, but I was just curious, and I was around for 18, 19 years, secondhand smoke from both sets of parents.
So chronic cough, the most common 5 reasons are asthma, COPD, postnasal drip, silent reflux, and something not very common in North America, but when your immune system attacks your lungs, causing eosinophilic pneumonia. Depending on what stage of sarcoidosis she has, if she has some scarring in her lungs, it could irritate things. But common things being common, as we move into spring, into summer, allergens could be a provoker for that cough or a reason for that cough.
And I think she was also concerned because she has a condition as well. Would that play into
sarcoidosis?
it? Yeah.
It's a multi-organ disease. It can affect the lungs, the heart, the brain, the skin. It depends on where in the lungs and how it's affected her lungs.
Is it separated then from the cough or related to?
One of the symptoms of sarcoidosis can be cough or persistent cough.
Okay. I want to talk about some groundbreaking research going on. In fact, there's research being done at the University of Washington. Researchers there are getting close to developing a cancer vaccine. And what's different is that this vaccine doesn't prevent cancer, but rather it attacks it in a way that's never been done before. I had a chance to sit down with a doctor behind this research who explained how it works and why she's hopeful it could lead to a cure.
The immune system has 3 things going for it that other different types of treatments don't have. Number 1, if you stimulate it in the right way, it's permanent. It'll be with you forever. It will be like a constant chemotherapy. Number 2, it's specific. Unlike chemotherapy that's infused, and chemotherapy will really attack every fast-dividing cell, T cells only recognize their antigen or immunogenic protein. So you have very few side effects with immune therapy. And finally, T cells, they can crawl out of the bloodstream and go to wherever the tumor is, whether it's in the bone, whether it's in the brain, whether it's in your liver. They're programmed to actually leave the bloodstream, go to where their antigen is, and divide and kill till there's no more of that protein left. So there's no more of that cancer left. So the immune system is the way we can eradicate cancer. And I think we finally cracked the nut to begin to figure out how to do that.
And it was a fascinating interview. We have posted that full interview on our website. Just go to ksps.org and click on Health Matters. It really is exciting research.
It is, and I have to say immunotherapy is kind of one of the newest ways we deal with advanced lung cancer. I can't speak specifically about this vaccine trial. I will say the history of vaccine trials have been kind of disappointing up until now. But there are new ways of using the immune system to treat cancer. And those are now FDA approved, and they're widely used in the treatment of advanced lung cancer when it has spread, and also recently been added to patients who now have stage 3 lung cancer. And both of these interventions have been shown to improve survival.
So quite often we hear about clinical trials available. How do people find out more about those? How do they qualify for a clinical trial? Because there is a lot of research going on. Where do you even find out or broach the subject?
I would imagine if they're seeing an oncologist, whether a radiation oncologist or medical oncologist, they would normally be fairly knowledgeable about the availability of clinical trials in that community. And sometimes if they're not available in your community, they may be available in a local, larger academic medical center. But we all, try to offer those as more or less, honestly, the standard of care, because that's how we get better at treating cancer.
Okay. We talked about the advances in radiation, also some incredible advances on the surgical side where they're much less invasive than we've seen in the past.
It's really changed things and made surgery much more available to people who may be older or frailer or have wear and tear. Around 2000 in the United States, people started figuring out, as they have with many surgical procedures, how to do full lung resections where you take out the tumor and a portion of the lung and all the lymph nodes with little keyhole incisions. It started with the gallbladder in the 80s, but the thoracic surgeons figured it out, as have the cardiac surgeons. And now 90% of the lung cancer work that I do is with port access. So people, instead of having a big incision where the surgeon's hand is going in there, we introduce a telescope and some instruments through small holes and do the exact same operation with video. And that's because of, obviously, technology and bright surgeons, and then other surgeons who copied them, like me. So I started in about 2006, and since then I've converted a practice similar to the rest of the country, where everyone got a big incision and was in the hospital to 7 days, to now 3 or 4 small incisions, and they're home on day 3 most of the time. We do take on higher risk patients now that we would have turned down. Those patients are going to stay longer, but oftentimes we would have said they're not a candidate for this because it's too much trauma to their body, and we've minimized that trauma. People like to call this type of surgery minimally invasive. It's not. It's very invasive. It's minimally traumatic.
So the recovery time is a lot less.
Much less. Much less. And so we see longer lengths of stay with lowers costs. It gets people back to work earlier, and we produce the exact same operation that we did with just bigger incisions. And of course, that's something that's going through all of surgery, not just thoracic surgery.
We have an excellent question. I was curious about this myself from David via email, who says, does vaping cause lung cancer? They have nicotine but no tar. A lot of people are using the automatic vapor thinking it's safer. Is that true?
I completely disagree. The American Thoracic Society does not advocate the use of vapor cigarette or e-cigarettes, and I agree. We really don't know much about vaping, though, and there's over 2,000 constituents, and when you do combust a sugar, it becomes an alcohol, and we do have case series looking at combustion of alcohol and lung injury. So it's not all equal. It's not a low risk. We don't know enough about it, but I wouldn't recommend it.
Yeah, there's 2 reasons. First of all, the latency from the exposure to the development of cancer is 20, 30 years. So we aren't going to know about the safety of this, probably for that kind of time frame. Second of all, there's pretty good evidence that people who vape or use e-cigarettes ultimately start smoking. Okay, although you think of it as a substitute, the reality is it often leads people to using cigarettes. So I would agree, it's not a wise idea.
Yeah, we're seeing a lot of teenagers use the e-cigarettes.
It's extremely alarming. It's what tobacco was 30 years ago.
And parents don't actually, we're unarmed, so we don't know. We haven't been necessarily told that it's bad, and my kid's not smoking, so maybe it's a good thing. And so that we're not addressing it with the same vigilance as we do when we see our kids with cigarettes. So.
I think the latency that was brought up is one of the concerns, because the reality is it's been widely sold to some degree as being a much safer process, and that's the challenge, is that carcinogenic exposures take a long time to prove. And so, I mean, it'll take 15, 20 years for us to really know that for sure, but we can't assume, you know, that it's actually safer. So.
And we really don't know some of the ingredients that they add and some of the flavorings. And when you combust those oils or those sugars and what they will do, but there are some bent signs in looking at animal models and what increased airway inflammation it's leading to in the immediate sense. But like you said, we won't know really what the long-term risk is for lung cancer for another 20 years.
So that's alarming in itself. Yeah. Radiation, surgery, chemo. What's the difference between chemotherapy and radiation? I think that's always confusing for people and how it's used.
Yeah, and it's, you know, they're frequently used in conjunction. You know, they're complementary in some degrees, but they do kind of have a little different role. So, you know, they're both causing DNA damage, which essentially means that you can kill cancer cells with that process. You know,
Is that why people lose their hair often with chemo?
Well, it can be, yeah, because we're actually causing damage to lots of normal tissue along the way as well. You know, for a lot of times with chemotherapy, one of our goals is to try, and Dr. Mulvey can speak to this more than I can, but, you know, we're trying to eliminate microscopic risk anywhere it might be in the body. Not only where we actually can see it on PET scans and where the tumor actually is, but also other areas that we know that there's a good chance there's cells that have floated off and has gotten to those locations. You know, radiation is a little different. Radiation is very localized, and so we're basically using a bigger, more powerful gun, if you will, kind of right in that region, you know, where we can actually target the tumor. So in the case, you know, for lung cancer, it would be based off of what we're seeing on the PET scan. And we're focused very intently on that with radiation and very focused treatments, and it's going to be very good at getting rid of those cells, but it does nothing for any potential cells that might be in other locations. And that's what the chemotherapy is also helping with. The other unique thing is that they tend to complement each other. They send, you know, if you do chemotherapy and then you do radiation, it actually means that the cells tend to be more sensitive to the radiation, so they actually can synergistically actually achieve better results than they would separately. And that's one of the reasons that a lot of cancers we particularly combine them as opposed to even do them sequentially for that reason. And lung cancer is a great example. There's actually, you know, it used to be that we used to do a lot of these treatments more sequentially. You do one and then you do the other. And there's been very good trials that show that in many circumstances for an average stage 3 lung cancer, the combination of doing them both together gives you much better synergy, much better results than doing them sequentially.
Okay. I want to sneak in another phone call from Lowell in Spokane. Hi, Lowell. Thank you for holding.
Hello.
Hi. You have a question?
I'm wondering if edibles or oils may be an option for treatment rather than inhaling the smoke through vaping or product.
For actually treating the symptoms of cancer, or how are you broaching that? With an edible, are you talking about marijuana?
Yeah, we were right. The inhaling the smoke can be a problem, but I'm wondering if any kind of transfer or treatment for cancer might be approached using an edible or an oil, cannabinol, instead of inhaling the smoke.
Okay, I think we're understanding what he's asking.
I think there is a role for medicinal cannabis or marijuana use, but I would probably defer to an oncologist how that plays a role concomitantly with chemotherapy. But inhaling, I don't believe anything except oxygen should be inhaled.
I would agree. No, there really is no proven benefit in terms of treating cancer using cannabinoids or marijuana or THC. We do use actually synthetic THC to treat nausea and vomiting, okay, and that actually, those drugs have been around for quite a while. I certainly have my share of patients who either do smoke marijuana or use edibles, and if that helps them get through their treatment, I'm actually all for it. But it doesn't change the natural history of the cancer.
Mm-hmm. Can it help relieve some of the symptoms from the radiation and chemo? Of course, we mentioned radiation doesn't quite have the symptoms it used to. But
yeah, but no, it can be very effective for that. And as mentioned, I mean, that's been recognized for some time, which is why we've got both synthetic versions that are very effective for that, as well as, you know, especially here where we can use the natural substances themselves. And so it is very effective for kind of helping with some of those symptoms. The other thing it can actually help with sometimes is appetite stimulation. You know, a lot of these patients are losing a lot of weight, and as they're going through treatments, if they're having nausea, if they're having vomiting, and one of the things radiation can do is cause, you know, difficulty and pain with swallowing sometimes if we have lymph nodes right up against the esophagus, and so you just don't really feel like eating very much, and that's one of the big challenges, because it's a lot harder to get through treatments if weight starts to decrease and patients aren't eating very well, and so the appetite stimulation portion of that can be helpful as well.
Okay. With just a few minutes to go, some final thoughts, a takeaway for tonight, something you'd like to leave the audience with, and I'll start with you, Dr. Mulvey.
I guess I would simply say, although lung cancer is one of the deadliest cancers that we deal with, it's actually also one of the most preventable. And can't say it enough. If you don't smoke, don't start. If you do smoke, you really need to quit. If you've been a long-term smoker, talk to your doctor about screening and how we might be able to reduce the incidence of advanced lung cancer.
Dr. Nisco.
I'd like to just voice some optimism. There have been incredible advances in the last 10 years that are going to change the trajectory of the disease when we do find it. Some people are going to get it when they haven't smoked, and some people who have smoked and quit are going to get it. The advances in immunotherapy are opening up a whole new way of taking care of people where the standard chemo hasn't worked, and it's going to work in augmentation with radiation therapy. The radiation therapy is going to expose the tumor, and we're going to harness the immunotherapy to go get it. The advances in minimally invasive surgery are making people who might not have had surgery have surgery, get curative resections, and avoid chemo and radiation therapy altogether, which they're not easy. And screening is allowing us to get to these people earlier when we can be very effective in their care.
All right, just a few seconds. Dr. Wagner?
I'd agree with that. All the comments so far, we're having much more progress on the cancers we're treating, but at the same time, we also want to prevent them as much as possible, because that's the best way to cure this, is not to get it in the first place. So.
And Dr. Patel, quickly.
Take ownership over your health. If you're breathless, if you're coughing, ask for help.
That's an excellent place to leave it. Thank you all for being here. I want to thank our panel for an excellent show this evening, for a great discussion. And our thanks as well to everyone who called in or emailed a question. We appreciate it. We'll be back next month with another edition of Health Matters. Join us on June 21st when our topic will be brain injury and concussions. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.